Hi, everyone, and welcome to this week's COVID-19 office hours. We are just going to spend a brief moment or two going over some tech notes and logistics, and then we'll turn things over to today's team of presenters. So first and foremost, just as a reminder, we are recording today's office hours, and we'll post a copy of that recording along with the slide content, as well as anything that comes in through WebEx's chat feature. All of that content will be posted to the HUD Exchange at the link that is up there on the screen. Just please give the team a few business days to get that information posted. Also, if you're joining the audio today using your computer, that's totally fine to do so, but if you have any audio issues throughout, we encourage you to consider switching over to your phone. That connection tends to be a little more stable for folks. And you can do that, switch over to phone audio at any time by dialing in the numbers that are both up there on the screen and in the chat box for you right now. In terms of connecting with the team today, you can do so by clicking on the chat button that appears in WebEx on the bottom right-hand side of your screen. Just click on that little chat icon and it'll open up that functionality in WebEx for you. Please send all questions, comments, feedback in through that chat feature. And when you send in those messages, just take a moment to please ensure that they go to everyone. It should default to everyone in the toolbar, but if it does not, you can go ahead and scroll down to make sure it gets to everyone on the call. With that, I'm going to turn things over to Norm Suchar from HUD's Office of Special Needs Assistance Programs. Norm?
Thank you so much, Natalie, and welcome today to our office hours. Thank you for joining. We have a great set of presentations today. We're delighted to share with you. So I'm going to introduce our presenters, and we will jump right into the content. First of all, you'll be hearing from several of us from the Office of Special Needs Assistance Programs, including Sharon Singer, who will give an update on ESG-CV a little later. We're very pleased to have Rita Harcrow, the Director of the Office of HIV/AIDS Housing at HUD, joining us today for an important message. We have Brian Roccapriori from one of our great TA providers who's going to talk about some of our resources that are here to help you with addressing COVID. We're very delighted to have a community presentation from Thomas Huggett, and he's from the Lawndale Christian Health Center. So that's a great community presentation we're very excited to share with you today. We will get our regular update from the Centers for Disease Control and Prevention from Ashley Meehan. And we will also have a brief presentation from Barbara DiPietro from the National Healthcare for the Homeless Council. So we have a lot of great content to share with you today. And so we're going to turn to the next slide, and I'm going to turn things over first to Rita Harcrow from HUD's Office of HIV/AIDS Housing. Rita?
Hi, thank you, Norm. I appreciate that. As Norm said, I'm Rita Harcrow. I'm the Director of the Office of HIV/AIDS Housing, and I just wanted to remind everyone about World AIDS Day, which is commemorated every year on December 1st. It's been 40 years since the first cases of AIDS were reported in the United States. During that time, we've made tremendous advances in HIV treatment, wherein individuals who are diagnosed with HIV are able to live much longer and healthy lives. But despite those impressive advances, HIV remains a public health crisis in the United States. The CDC says that there were 1.2 million Americans living with HIV in 2020. That disproportionately impacts racial and gender minorities in our country. And further, there were more than 36,000 new HIV infections in that same year. HUD recognizes the role of housing as a key structural intervention to reduce those disparities. HUD's Office of HIV/AIDS Housing administers the Housing Opportunities for Persons with AIDS, or the HOPWA program. HOPWA provides funding for housing assistance, supportive services, and administration to states, cities, and nonprofits in all 50 states and territories. The HOPWA program serves over 100,000 households annually. Recently, HUD made available for competition $41 million in competitive funding to state and local governments and nonprofits through a competitive NOFO. Those funded projects, which we hope we can announce on World AIDS Day, will offer innovative solutions to housing as a tool to end the HIV epidemic. including increasing coordination with local housing providers and advancing racial and LGBTQ+ equity. HUD will also have an expanded role in the National HIV/AIDS Strategy for 2022 to 2025, which we also anticipate will be announced on World AIDS Day. And that strategy will promote collaboration across agencies and public sectors to meet the needs of people living with HIV and to proactively work to prevent new HIV infections. HUD is proud to recognize our progress in fighting the epidemic, and we seek to expand our role in providing housing to those diagnosed with or at risk for HIV. I invite you to join me in standing in solidarity this World AIDS Day with those who are living with HIV and AIDS, and to continue the work towards ending the HIV epidemic. And on this slide, you'll see some ways that HUD is planning to recognize World AIDS Day on December 1st. So please keep an eye out for those things, and remember to follow HUD HOPWA for updates on Twitter. Thank you.
Thank you so much, Rita. Great message to be sharing, and encourage you to definitely follow the HOPWA Twitter account. And if you have any questions for Rita about the Office of HIV/AIDS Housing, the HOPWA program, anything else, feel free to type them in the chat window. With that, we're going to turn to our next presentation. We're going to hear from Ashley Meehan from the Centers for Disease Control and Prevention. Ashley, it's all yours.
Thanks, Norm. Hi, everyone. My name is Ashley Meehan, and I am with CDC's Homelessness Unit within our COVID-19 emergency response. So it's good to be with you. Next slide, please. All right. I do not come bearing the best news. We are seeing cases starting to go back up again. So we have more counties in the red zone than we did previously, and we can see that the number of counties moving into that red or that high community transmission status has increased. So we are seeing more counties moving up into high transmission, which is not the direction we want to be heading, but that's okay. We're still, doing the best we can, and it doesn't mean that things are doomed just yet. Next slide, please. When we look at the forecast for where it's projected to be heading over the next 4 weeks, it does show that it will probably increase, but we're hoping that this forecast is true and that it doesn't increase at the rate with which it has increased for previous surges. But this is also kind of to be expected as we're moving into the colder weather and into the winter holidays, and people are starting to see more people, maybe do some traveling and leading to higher community transmission. So I do just want to put this on your radar that cases that were coming down are now plateauing and maybe increasing, and just want to make you all aware of that as we move forward. Next slide, please. Similarly, or I guess also relatedly, vaccinations in the U.S. are also kind of at a plateau. This map shows the percent of the total population in each county that is fully vaccinated. So 2 weeks after a single dose of the Johnson & Johnson or Janssen vaccine, or 2 weeks after a second dose of an mRNA vaccine for Pfizer or Moderna. So we can see that there's still quite a few places that have less than 40% of their total population fully vaccinated. Hopefully this increases as children ages 5 and older continue to get vaccinated, and hopefully more people who have been eligible for longer are also choosing to get vaccinated. So hopefully we see this continue to go up. Next slide, please. And I do want to highlight two things from the news and one of a recent publication that came out this week in the MMWR. So first I'll start with this MMWR. It looks at the effectiveness of those 2-dose mRNA vaccines. So those are Pfizer and Moderna. It looked at their effectiveness at preventing COVID-19 hospitalization. So we know a little bit about their ability to prevent infection. We know that it's not 100%. We know that breakthrough infections occur. But how effective is it at preventing hospitalization and severe illness? That's what this MMWR was looking at. and they looked at specifically people who are immune compromised and people who are not. So they compared these two groups against each other. And how they did that was looking at people who were hospitalized and had a positive COVID-19 test. And they looked at their different characteristics and factors to assess vaccine effectiveness. And what they found is that vaccine effectiveness for COVID-19 hospitalization is lower for people who are immune compromised than it is for those who are not immune compromised. So the vaccine effectiveness for hospitalization for those who are not immune compromised was about 90%, and those who were immune compromised, it was around 77%. So still really high vaccine effectiveness, but do just want to note that if people in your community, in your population, in your circles are immune compromised, the authors of this paper conclude that they really should be getting their third dose and their booster doses to make sure that they have as much protection as possible. So I do want to highlight that. And one of the reasons that that is really important can be on display from Connecticut. So recently we came across this news article from Connecticut that they had a pretty large outbreak at a nursing home. I know we often present articles about nursing homes on these calls, and we know that the settings in which you all work are likely different from nursing homes, but it's the best available information we have that we can compare to. So in this particular outbreak, I found these numbers really sobering and striking, and I just want to share them with you all, just because, you know, it's something that we're keeping an eye on, and I want to be transparent about that. So in this outbreak, 22 staff and 67 of the 70 residents in the facility have tested positive for COVID over the last month and a half. Only 2 of the people who tested positive were not vaccinated, and then 8 residents that had serious underlying conditions have died. So I can imagine that it's easy to hear this and think, you know, what the heck, most of them were vaccinated and they're still getting sick and people are dying. And I can see how that might be a little bit disheartening, and I think it's a fair question. But I think it's worth noting that, you know, breakthrough cases can happen, they do happen. We know the vaccine isn't 100% effective at preventing infection, but we also know that there is a pretty high effectiveness at preventing hospitalization and death. So, you know, while 8 people passing away is not an ideal outcome, I can only imagine how much worse it would have been if more people were unvaccinated. So I think, you know, if you're serving a population that's older, has underlying conditions, is immune compromised, it's really important to make sure that they're getting both a primary series just to start, but then also their booster doses and their third doses. And I would be remiss if I did not use this chance to also say this once again emphasizes the need for these layered prevention strategies. So we cannot rely on vaccinations alone. You know, I'm sure you all are feeling tired from hearing this message and feeling like you have to, you know, hear this again and again and again, but it's really important that, you know, we keep masking in place, we keep distancing in place, we make sure that we're washing our hands often and encouraging others to do the same. Just because these outcomes can occur, and as we're moving into the colder weather and, you know, shelter census may increase, you may take in more people. It's just something to be aware of. You know, we are doing the best we can. You all are doing the best you can. We're really thankful for you, but just want to share the science that we're keeping an eye on. So happy to answer any questions in the chat, and I'll pass it back to you, Norm. Thanks.
Thank you so much for the update, Ashley, and for the information. And again, if you have questions for Ashley, please feel free to type them in the chat window. We're going to move to our next presentation. We know that a lot of people have questions about the administration's vaccine mandate rules. We have Barbara DiPietro from the National Healthcare for the Homeless Council to help answer some of those questions. So Barbara, I'm going to turn things over to you.
Thanks, Norman. Thanks, everybody, for being here. I want to pick up where Ashley left off and just say, I know that we have all been working hard on the vaccine piece, but here's more information. As many of you know, earlier this month, the Biden administration released 2 sets of rules that are going into effect immediately. And so just want to talk through a little bit about what these rules have in them, but particularly how these are going to apply to homeless services and the work that we're doing. So next slide. So just real quick, there's two rules. One is from OSHA, which governs workplace safety. This rule applies to non-healthcare private employers that have more than 100 employees, so larger employees. If you're working for Catholic Charities or Salvation Army or some of those larger organizations, regardless of how many sites, it's really at about an organizational level total, this may apply to you. And then there's a second rule. The important piece with the OSHA rule is that it's a vaccinate or test requirement. The CMS rule that came out applies to nearly all healthcare providers. And this is the one that mandates vaccination without having a testing option. Now, both of these rules, of course, will follow the federal requirements for issuing medical or religious exemptions. But the larger goal, of course, to both of these is to increase COVID-19 vaccinations amongst staff. Next slide, please. Okay, so here is just a couple of things about the OSHA rule. It was like 500 pages, so I want to try to save you the trouble of going through all of that. And here's just some important takeaways for the OSHA rule. One is that this is by December 6th is the idea is that all requirements are implemented to include creating the policies that are required under this rule, except the testing piece. And January 4th, that's when the testing as an alternative to vaccination goes into effect. Now, the important details here are that pretty much immediately after introducing these rules, there were lawsuits that were filed, and now the OSHA rule has been stayed pending further legal decisions. So we don't know what the outcome of this is going to be, but if we just presume that this will go forward in that, it's better for us to be prepared. And so obviously, we are trying to move toward a culture of vaccination. I know many of you may be calling in from communities that did not have a culture of vaccination, or you may not be supported the way you need to by your policymakers. But then some of you are coming in from places where vaccines have really been, and the mandates have been more of a norm. But the OSHA rule requires weekly testing at employee time and expense. These rules are a minimum standard. So if you're in a community or in a state that's setting higher standards than these rules, then those higher standards will apply. If you are in a state that is imposing lesser or lower threshold, then these standards will preempt what your state or your community is doing. Again, I imagine we're going to have a lot more to hear from the courts on how this plays out, but it's just important to see what the direction of this is going. I mentioned that, again, any exemptions does have federal law still apply here, but state laws have got different pieces around what those exemptions look like. For example, some states do not allow religious exemptions. So again, that higher standard will apply, with this one being a minimum standard. It also requires that if you have employees at large employers that are unvaccinated, they have to remain masked while at work, unless they're a 100% telework position, or this is 100% outside work. One of the things that's important as an employer to keep in mind is that there's a lot of administrative tracking. So you have to keep track of all of the vaccination status of your employees and of all the testing results that are happening. Employers do need to provide 4 hours time off for people to get vaccinated, and providing reasonable time and paid leave for any side effects. It does, I think, importantly, prohibit employers from discriminating or taking retaliatory action against anyone who might want to wear a mask or who may want to get vaccinated. It prevents an employer from discriminating against masking and against vaccinations. I think importantly, too, for folks who are working in an area where you have a diversity of workforce, it does require that information is provided in all languages. Now, I think that HUD and the federal government have done a lot of work to provide information in many different languages. So this is not a material that employers need to develop new, but using what's been created to make that available to employees is important, so that everyone understands why the vaccination rule is in place and why that's important for not only their own health, but the health of their colleagues as well. And then finally, it's important to say prior COVID-19 infection does not exempt employees from any of these requirements. So that is kind of a condensed version of 500 pages of rule. And so just the takeaways for you to appreciate on that piece. If we go to the next slide, however, we get more into some of the healthcare rules. And this is where I think we might also kind of have some pieces that are going to apply to a number of you who are here today that may not be in a large organization with more than 100 employees, but you do have close relationships with healthcare providers. So for the last couple of years, we've been doing all this. We've really been emphasizing the kinds of partnerships that we want between homeless services and healthcare. Tom Huggett, coming after me, is going to talk a lot about what they're doing in West Chicago at his site about doing that integration. But it's important to know that for all healthcare providers, there was a separate rule issued from CMS. And again, same dates for when December 6th, when all employees have to have at least one vaccination or submit for an exemption. And then by January 4th, everyone has to have had completed second dose, or if you're J&J, just one, or have an approved exemption. Now, the details here is that this covers a broad range of people beyond just employees. It covers volunteers, contractors, students, interns, housekeeping staff, security staff, facility staff, anyone who is on site regularly at a healthcare facility. This rule applies. If anyone goes to off-site facilities, like for example, does outreach and encampments, goes to supportive housing sites, this rule applies. And again, much like the OSHA rule, this is a minimum standard. So this will preempt any state rules that are a lower threshold than this. But of course, if your state has a higher threshold, then that will apply. Again, the exemptions are still part of federal law. They still apply here. And again, prior COVID vaccination does not exempt employees from these requirements. Now, here's the wild card that I think we need to really pay attention to here, is that there's a lot of different relationships that you might have with healthcare providers. A number of you might be having shelters where you have a clinic that's inside the shelter. You may be in and out of other of your partners' facilities. You may have shared interdisciplinary teams going to client houses or client service sites. There's a lot of integration that we've done, especially over the last 20 months, that might make this apply to other homeless services. Even if it's not the OSHA rule, it may be this rule because of your relationship with a healthcare provider. So this is why I'm calling this the wild card, because we just don't know. You will know your relationships best. And I imagine that at your local level, there will be more than one attorney who is determining who and when and where this applies based on either formal or informal relationships. So ultimately, really the advice here is have active discussions with your local partners about what applies here and how your employees are going to be subject to the CMS rule. So even if the lawsuit that has put the OSHA rule on hold continues to be on hold, the CMS rule has not been put on hold. This is moving forward. And so again, this is the kind of thing that might more likely impact more homeless services providers than the OSHA rule. So again, just want to emphasize, talk with your folks locally, see what relationships you do have, what your physical spaces look like, and be talking really about which employees are going to have to be mandated to be vaccinated with no testing alternative. So again, I think that this is really important. I know this is a sensitive topic, particularly in a lot of communities, but ultimately we really are trying to move toward being very highly vaccinated in our workforce so that not only are we protecting ourselves and our own families, but we have safe workplaces for everyone to be. And then that makes a safer place for us to serve very vulnerable populations. So I think that's really the goal that we're all moving toward. And if we can go to the next slide, I will put links, and it might be that Letitia is already, I see that she's already put some of the links in the chat. Thank you, Letitia. So these slides are here that have some more rules, it's just some more information. And with this, I am really pleased to turn this over to my colleague, my friend, Dr. Tom Huggett. He is the medical director for mobile health out at Lawndale Christian Health Center in west side of Chicago. He has been working tirelessly since the beginning of this pandemic to deliver healthcare to the clients that we're all serving. He has been working with his COCs to do great integrated work and standards that he's going to tell you about. But again, I just can't say how much I appreciate you being here, Tom, to talk with us about all the work that you've been doing. And so with that, I will turn it over to you. Dr. Huggett, take it away.
Well, thank you so much, Barbara, and thanks to Norm. And it's really an honor to be with all of the HUD folks and everyone who is participating. I work as a family doctor at Lawndale Christian Health Center. I am seeing patients actively in shelter settings and also in my clinic settings. So I was seeing patients yesterday. I saw them Tuesday night and Monday. So I'm an active clinician seeing patients. I do quite a bit of work in substance use disorder and with folks with severe mental illness. So I'm also kind of representing our great team at Lawndale Christian Health Center, which, as Barbara said, is on the west side of Chicago, and also the other major healthcare for homeless provider in Chicago, Heartland Alliance Health. And I want to give Mary Turner-Benny's name out there too, who leads that effort. And I do want to say that we're also kind of representing a little bit some of the healthcare for homeless folks throughout the country. Barbara has really brought us together every 2 weeks. So we have people from Portland, Maine, DC, Atlanta, Houston, San Diego, Yakima, Washington, Chicago. So it's really a wonderful exchange of information. And what I can say, what's happened really since March 2020 is that this coronavirus pandemic has really almost forced us all to work together in collaboration. So I really have to give my credit to the Chicago Department of Public Health, Department of Family and Support Services in Chicago, which helps to administer the shelters, All Chicago, which is the COC in Chicago, our behavioral health, our Chicago Health Partners, and things like that. So, what happened here in Chicago is that Chicago Department of Public Health prioritized housing and vaccination for people experiencing homelessness. And for that, we are very grateful, especially those of us who have been doing work and serving people experiencing homelessness for the last 25 or 30 years. On the next slide, we'll just see that Lawndale Christian Health Center is a federally qualified community health center on the west side of Chicago. And you can see those blue dots are the shelters that we serve. You can see on the right-hand side, the blue of Lake Michigan. We're serving 12 homeless sites weekly and in about 6,600 encounters in the last 12 months. So we're really, what's important about this slide is that the pandemic really built on this work that many of us have been doing for 20 or 30 years, providing primary care, behavioral health care, social services, and substance use disorder treatment within the shelters. So it was really those relationships that we already had that we really leveraged as we went into the pandemic. And as Barbara said, in the next slide, we really see the first lesson. There are going to be 4 lessons in this presentation, but the first lesson is really kind of developing standards of care for persons experiencing homelessness. Mary Turner-Benny was the main author of this. I was pleased to help with this. And what this was is using input for persons with lived experience of homelessness. We really tried to define the approach. What is the approach of this? And some of the main features are on-site care. We really need to be on-site. We never left our shelters during the pandemic. We continued to see people face to face. We did not go telemedicine with our people experiencing homelessness because many folks did not have phones. We feel we're much more effective in that relational aspect in being on-site care, having a regular schedule, being there regularly, providing medications directly to the patient rather than just giving prescriptions, using evidence-based quality care and things like harm reduction and engagement in relationships. One thing that's really important, I feel, is that what we're not only dealing with the patients or the guests or the participants in the shelters, but we're dealing with the shelter staff. This is so important because we want to make sure that the shelter staff themselves feel really supported, and that's part of what is going on. So these standards are in the website that you'll see down on the lower left-hand corner under shelter resources if you'd like to take a peek at those. For us at Lawndale, on the next slide, I'm going to show two different ways of providing care. You'll see that this is Walls Memorial CME Church on the upper left-hand corner. In the basement of that church, as you can see in the lower left, they put out cots for 70 guys to sleep at night. What we do is on Thursday nights, we come in and we put partitions up, and we're operating out of a suitcase. We bring everything with us, and Heather Duncan is the nurse practitioner in the foreground of this is a pre-pandemic photo, of course, but you can see that we're operating literally out of a suitcase where we have medications. In the far part of the photo is where the registration and where our behavioral health staff are really trying to assist clients with some of their social and healthcare needs. So when we're talking about mobile health in our mobile health context, we're the ones that are mobile. Now, there are plenty of, and the reason that this is that in the Chicago context, about 70% of people experiencing homelessness are within shelter settings. There's certainly a street outreach, and I take off a hat to the people who are doing street outreach and working in encampments, such as Night Ministry, Chicago Street Medicine, and Heartland Alliance Health. But our model is working within the shelter setting, out of the suitcase model. And then the next slide really shows where many of our shelter sites, we have actually coordinated with the shelters to actually have a room, an exam room, as you can see, where we can actually store, we can have a locked cabinet where we store medication, dispense medications directly. In the upper right-hand corner, you can even see a little refrigerator in the corner. So that's where we've been storing now, where we're able to store our coronavirus vaccines and our flu vaccines right now. So that's another model of care. So the next slide really shows the next lesson. So what we want to emphasize with this is that, we were through the pandemic, at the start of the pandemic, we were building on some of those relationships and some of that primary care that was already existing. And as Barbara said, we integrated some of this into our care that we were already doing. So what we do really, what sharpened our focus through the pandemic was the disproportionate effect, of course, that coronavirus had on our on Black and other minority populations. 70% of COVID-19 deaths in April in Chicago were Black. 70% were Black, and that really focused us very, very carefully. Looking at Ashley's graph, you could see that the little bump in April, and that hit us hard here in Chicago. And so we really wanted to say, well, when we're looking at engagement with our patients to help to provide care, to do, protect PPE, for example, and also when we got into vaccine engagement in January and February, we really kind of needed to have a conversation and really define, well, what does it actually mean to be anti-racist? And so these are just some bullet points that I think that some of us may have found to be helpful to acknowledge the past and present systemic racism and really start a conversation. We were wanting to ask what people have heard, because a lot of folks, they look at social media on their phones, and we can say, hey, there's a lot of confusing information out there. I think one anti-racist thing that we found to be helpful was ask permission. Ask permission to share information. Can I tell you what I heard? Would you mind if I showed you this one pager from New England Journal of Medicine on an mRNA vaccine that came out in December or January? I can't tell you how many people really appreciated me showing them that New England Journal article and showing them what the science actually was. Can I share you with my own experience? Yeah, when I got my vaccine, my arm was a little bit sore. I took a little Tylenol and I did okay. But asking that permission is really, really, really important. And being honest about those side effects. Like I said, my arm was a little bit sore, but you know what? I actually felt good about that because I felt like it was revving my immune system up. So be honest about the side effects, but also clearly state that, for me, it was worth it because I didn't really want to get coronavirus, and really state clearly what the recommendation is. We also emphasize messengers from the same racial or ethnic background. Tyler Perry's video was a huge hit. Throughout many of our shelter settings. We had Zoom calls with shelter staff, including our Black psychiatrist, Black director of behavioral health, one of our Black doctors, and it really, really made a difference. And people exchanged their phone numbers. So many of our shelter staff who may have had the experience of homelessness themselves were texting our folks back and forth. That seemed to be very, very helpful in not only engaging staff, but when we engage staff, we engage the guests as well. And then I think that we also wanted to work with our patients to make their own plan and really respect that plan. So what that led to on the next slide is really showing what happened after we did that engagement. And we're really we had a lot of people working very, very hard to do engagement sessions. You can kind of see we had posters. We made this a huge, big event. We had posters and we asked people, well, why did you get the vaccine? And we did, we actually had Polaroid camera photos, and we put Polaroid camera photos and the messages up here and gave people stickers and really tried to make it a big event to really try to mobilize folks in getting people vaccinated. And I did get some up-to-date information. The 52% receiving at least one dose. Well, you know what? That is 86% now. 86% of folks who are sheltered in Chicago have received at least one dose. We also have to say that 430 folks were also immunized by our street medicine team. So we cannot discount that. That was a huge step forward. And like Ashley said, I mean, we are seeing some outbreaks. I hate to tell you, Ashley, but we did have a little outbreak. Actually, we're having an outbreak right now, as of this yesterday and this morning, where we had 2 breakthrough cases. So these were folks that we immunized in January and February. They're fully vaccinated, have not received the booster yet because we're rolling out the boosters now, but they are not as sick. They went to the isolation. We had a couple additional people under investigation. We did some rapid testing this morning, and we had 2 additional cases that will also go to isolation. So this really motivates us and motivates the staff and our guests to let's get the immunity up a little bit. Let's get our booster shots. Besides the immunizations, on the next slide, it really shows some of the shelter infection control measures that we did for not just the 12 shelters that we do primary care, but an additional 24 shelter sites, including a lot of domestic violence shelter sites and a lot of smaller shelter sites where we did invest in infection control training. So you can see the ladies in the upper right are not medical staff. These are shelter providers that were trained on how to do coronavirus testing. This was using the ID Now machine back in the summertime, where they knew how to do the test for somebody if there's a person under investigation. Then we did the training for the Binax Now cards. So those are the cards that we're doing for rapid testing. But you can see we did 19 engagement sessions, 155 hand sanitizers. You can see the HEPA filter in the lower right, and 28 plexiglass shields were all installed. Heartland did this stuff, provided these in their shelters as well. 36 shelter sites for Lawndale, 60 shelter sites for Heartland in Chicago. So we were really we really worked hard all together to do this. And the next slide really shows the next lesson. And this next lesson really, I hope will resonate with hopefully, you folks at HUD, because one of the challenges that we're seeing is, how can we share data more accurately? And just to start, how can we determine an accurate denominator? How can we actually know the total people experiencing homelessness? Now, we were using the point in time count, as you saw, but we know that point in time count really fluctuates quite a bit. And we just really feel that perhaps the HMIS numbers that are there may be more accurate, but there have been really lots of challenges and misconceptions about HMIS data sharing, even with City of Chicago, and certainly with us as healthcare providers, even for very important public health information such as vaccine status. So one question that I would have, I guess, perhaps for the group is how could we improve data sharing? How could, especially in a pandemic, but even moving forward outside a pandemic? So this really touches on, how the intersection of healthcare and housing works together. On the next slide, it really shows one of the interventions that happened in Chicago, which was where we were able to protectively house 259 very high-risk people experiencing homelessness at a downtown hotel from April until September. This was an amazing, operation. You can see the picture of the hotel in the lower left. This was on Superior, right off the Magnificent Mile. 28 stories. I know 28. It was 28 because I slept on the 28th floor. So I was on site at that location pretty much all the time, except for when I went home to do my wash. But it was really an amazing experience. We had 66 people who actually had coronavirus, and many of them went to the hospital, but I'm happy to say that nobody died. What we also showed in this intervention is that there was a 2.5-fold reduction in infection, which is pretty amazing. Significant decreases in blood pressure, better diabetes control. We had 9 people taking daily methadone. We stored the methadone in the hotel safe and dispensed it daily. So you can see that we had a lot of substance use disorder, lots of mental illness. So what the other thing in terms of housing and what you're probably most interested in is that out of this, we did accelerated moving events, the AMEs, where we were able to have 132 people achieve housing out of the hotel. And you can see that one of our patients on the lower right is exiting into his housing and going in the hotel lobby. And we're giving him claps of hands and Dunkin' Donuts on the way out. And so we were really, really pleased. So this was the kind of a first accelerated moving event that happened. After the hotels closed in September, then in the next slide, it shows that we continued to do accelerated moving events working with All Chicago, our COC partner. And this is just looking at, this is a little bit of a pilot where a healthcare team really looked to see if there were certain needs that we could identify to stabilize people in their housing. So what we really found was really interesting, and fortunately the number is easy, right? 100, so you can kind of do the percentages easily. And 20, a fifth of them, we saw them for the first time when we did this 15-minute interview, when we were asking them about social service supports, physical disabilities, can you walk upstairs, a functioning limited serious mental illness, and whether they needed medications for substance use disorder. We worked with our behavioral health partners thresholds here in Chicago, and we did a warm handoff directly to them if we identified someone who really had some severe mental illness who really needed ACT or CST or RST support. And 28 were open for that. So you can see that we really identified lots of supports that were needed to try to maintain housing. So what this leads to the next slide, which is really lesson 4, which is really that intersection of healthcare and housing that you're so interested in. I'm pleased to report I just came from a meeting this morning where they said that 1,219 people have been housed through expedited housing initiative through this week in Chicago since the hotel. So 1,200 people have been housed. Isn't that amazing? Through rapid rehousing. But what we really need to do is that how can we really support people? How can we maintain that housing? How can we retain them? I have many folks actually, unfortunately, who kind of, abandoned their housing because they weren't getting the supports they needed and ended back up in the shelters. So there are several reasons for that, but how can we get the supports that they need? And the question that I might have, and some of my colleagues, is would COCs actually benefit from representation by active clinicians like me and so many others who actually serve people face to face to really see how we can retain those supports? And would appropriate housing and health be improved by requiring everybody in a shelter to actually see a healthcare provider at least once? My argument is it may be. We could see that there are a lot of needs there that we saw just when we did the health screenings and the accelerated moving events. And then finally, what are the accountability mechanisms for COC? How can we interact? The city really doesn't, have sway over the COCs. We as healthcare providers don't, the shelters really don't. So how can we give feedback to our CICs to make them even better? And the last slide is really showing that really summarizes from Mother Teresa what we've really learned through this pandemic in these last month and year and 3 quarters, is that social connection is so important. We can talk about supports for severe mental illness, for substance use disorder, for social connection, for other things, but that social connection is just so important. And those are the reasons that sometimes our folks are coming back to the shelter rather than staying in their house, because their social network is within the shelter. How can we create a positive social network for folks who are in their own housing? And how can we meet those social, medical, and spiritual needs so that they can retain their housing? So thank you so much for this invitation, and look forward to any sort of comments or questions.
Thank you so much. That was a fantastic presentation. You got through, gave us a ton of good recommendations and lessons learned. I want to go back a little to some of the suggestions you had about anti-racist actions, because racial equity is something we try to focus on a lot because there's such a need for more work there. So can you talk about how did you develop these sort of recommendations? Who did you work with in the community? Can you talk about, like, for people who are trying to figure out, like, who want to do better and want to figure out, okay, what are the first steps? How do I learn more? How did you guys sort of approach that, and where did you go for information, and how did you sort of develop a set of activities that you were going to do to help promote anti-racism?
Well, thank you very much for that, Norm. There are a couple ways, I think. Primarily is listening to the folks you serve. I mean, really giving voice to the people that you serve as well. So when we were at the hotel, let me just give a quick example on that, is that, in April and the beginning of May, the folks were pretty much confined to their hotel rooms. We were scared. I mean, people were dying left and right. We were hearing about it, and, we wanted to, maintain them within the hotel rooms. However, it soon became evident that this was a bit too restrictive, that we needed to recognize agency. And our folks were telling us that verbally and also voting with their feet. So we had some people leave the hotel AMA, against medical advice. They just disappeared because, there were about 15 or 16 people. And then we said, oh, we got to do something here. We listened to folks and said, hey, let's institute smoke breaks, because, we were trying to give people nicotine patches, but no, there were some people who just wanted to smoke. So we had supervised smoke breaks. Let's say people wanted to pick up their Social Security checks on the first of the month. Okay, let's give you a day pass. Go out. And for some of the folks who we were a little, they may need a little bit more supervision because they may have more active substance use disorder, we accompanied them. We went with them. So I think to answer your question, Norm, is one, the first thing is to listen to the folks that we're serving, and to kind of hear, what the reasoning is, and, what can we make it better? How can we make it better? And the second thing, I think, is to listen to our staff. Listen to our staff who are Black, or who are other minorities, and also our shelter staff, to say, hey, what's the best way how can we approach these? And this distillation is probably a distillation of a couple of pages, but I wanted to kind of distill it a little bit of some of the techniques that we found to probably be most helpful. Because it really is hard, right? I mean, it's easy to say, oh, you just have to be anti-racist, but what does that actually mean? What does that actually mean in practice? What do you have to do? And so these are just some of the examples that we kind of came up with.
That's fantastic. Thank you so much, and great advice. The other thing I wanted to not so much ask about, but just sort of to highlight, is the incredible work to rehouse people who were unsheltered in Chicago. I think that's kind of an amazing accomplishment, and kudos to you and everyone in Chicago who sort of put that together and made that happen. I think it's, again, an incredible accomplishment. Saved a lot of people's lives, definitely improved people's well-being dramatically, and it just wanted to highlight how fantastic an accomplishment that is. It's just very heartening to see that. And 1,200 people is that's a lot of people. That's just amazing. So definitely wanted to highlight that, and also wanted to say we hear you about data, about the other things you talked about. So thank you for spotlighting those things. And in fact, our next presentation, that's a great segue. I want to turn things over to Brian Roccapriori. He's going to talk about some TA resources and maybe touch a little on data sharing. So Brian, I'm going to turn things over to you.
Thank you, everybody. So I'm here to re-highlight 2 TA resources that are available on the HUD Exchange right now because the winter months are here and we really wanted to emphasize the importance of vaccination efforts. We heard it earlier on the webinar today and on previous office hours that we can't rely on the vaccination alone, but the vaccine is the best tool that we have to get this under control. More and more information is becoming available on vaccination rates of people who are experiencing homelessness. And we did just hear some great numbers out of Chicago. I think it was 85% of folks in their shelter. That is amazing. But there's other studies out there. One recently out of Madison, Wisconsin, where they managed to match their homeless management information system, their HMIS data, to their state immunization registry. And that showed their unsheltered population at a vaccinated rate of around 24%, compared to the general population, which was 74%. So that's a pretty wild swing there, and it just shows that there's a lot of opportunity for us to do better and do more. Thomas had asked in his last presentation, and I'm glad he did, like, how can data sharing be improved? So if anybody out there is thinking of leveraging their immunization data with their homelessness data, there is a product for that, and that is in the chat box right now. It's a great place to start to show how you can start to leverage your HMIS data with your state's vaccination registry. On the next slide, there's a transportation document that was put together earlier this year. That should be also in the chat box right now. And what I want to say here is, if at all possible, try to bring the vaccine to where people are. That's the best possible scenario. And we recognize that that's not always possible. So if you are transporting people off-site, it's going to involve a plan so you can make sure you do that successfully and safely. This document was put together about a year ago in a time of vaccine scarcity, but there is a lot of great considerations in there that folks can still take into account today. And while the document itself focuses on larger groups of people getting moved around, like using buses and vans and such, that isn't really the reality we find ourselves in now. So what I want to stress is that the funding doesn't have to be used to transport a large number of people to an event. I mean, if you still can get a bus full of unvaccinated folks to go get vaccinated, that's fantastic. That document will help you out there. And if you can do that, we would love to hear about how you're getting so many folks there and possibly highlight you in the next office hours. But the probability of that happening right now is probably pretty low. But funding can be used to transport one person to a place like a retail pharmacy with a ride share or a taxi or bus or whatever. And transportation can include a staff person going with that person if that is the point of hesitancy that's going to get them to that vaccination. And transportation can be used to get people to their boosters. The document itself goes over a lot of considerations folks can take into account when they're planning these things. Stuff like making sure that appropriate accommodations are there for folks with disabilities. If this is a company vehicle, making sure you have the proper insurances in place. And if you're working with folks in an unsheltered situation, make sure that it's the person-centered approach and you're offering things like someone to stay and watch their belongings if that's a concern. And it also goes over how vaccine ambassadors can play a role in that planning. So on the next slide, and going into the chat box, we've developed guidance for vaccinating unsheltered folks using 3 different strategies: encampments, rural, and mobile events. Because there's no single right way to do this. So this document provides some guidance for communities that can pick what works best for them. Regardless of what you do, strategy should include the following principles when you're making your plans. And it starts with a multi-pronged approach, which includes open and honest communication, which can mean just listening to people and validating their concerns and giving them a trusted source of vaccine information, like a healthcare provider or an outreach worker who can answer their questions for the folks that don't have that confidence in the vaccine yet. With the general accessibility that we have of vaccines today, pair that with a plan to access the next available vaccination wherever or whenever that might be. All aspects, if you are planning a vaccination event, from planning to implementation, should be trauma-informed and led with empathy. And Thomas hit on this in the last presentation. Make sure that planning efforts include people that are representative of the community that you plan to serve and takes into account that present-day discrimination and historical mistreatment of folks who are experiencing homelessness, specifically the Black, Indigenous, people of color population. And this is a time where you should really try to maximize time with clients. In an ideal world, everything we do is housing-focused, and every interaction with individuals is an opportunity to start that connection with permanent housing. So consider who should be available to best connect these individuals with what they want and what they need. Each strategy should really factor in safety considerations, which clearly are going to differ between those 3 different strategies. Rely on providers that have experience working with the population that you're going to be interacting with to offer guidance and expertise to make sure that all staff and volunteers understand safety plans prior to any vaccination event. On the next slide, we start with a really great case study from Oahu, Hawaii, which is going in the chat, and does a great job showing how they were able to do vaccinations in remote, unsheltered settings. Things you're going to want to think about is where you're going. So in addition to your HMIS data or your coordinated entry data, your by name list, identifying where you need to go for outreach should utilize the expertise of the street outreach or street medicine teams that are familiar with unsheltered populations. Individuals who are living in unsheltered populations are awfully highly mobile. So if you do need to track folks for a second dose or help them get to that second dose, leveraging people's expertise here is critical. And I know I said this on the last slide, maximizing time with clients, but that 15-minute observation period after a vaccine is a great opportunity if you're going to start working with that person on a housing plan or connecting to services. If you are using that, or if you are using HMIS, ideally, all your street outreach programs are, having a place to do that information privately is a best case scenario. And last on this slide is consistency. If you have a regular time and location for folks to get vaccinated, keep it as regular as you possibly can. And on the next one, we start to go over the strategies. And this is all outlined in the document, so I'm just going to hit the high points here. Vaccinating individuals in encampments might mean that it doesn't happen Monday to Friday, 9 to 5. So consider when folks are most likely going to be at the encampments and go from there. And all of these sites are different. They can be extremely formal setups. They could be extremely informal. And if there is an existing leadership within an encampment, include those individuals in the planning process to ensure better turnout and better participation and acceptance of the individuals that are living there. And encampments are where people live. They're their homes. That follow the lead of the folks who you're serving and really minimize intrusion into their personal space. Again, listen to the people and considering setting up outside the perimeter of the encampment if that is what the people are telling you. On the next slide, we have some rural strategies. Folks who work in rural areas know that gathering places in rural communities often look different than in cities. So this is where communities can rely on their local experts to identify locations. Rural areas often don't have dedicated street outreach projects or street medicine projects or healthcare for the homeless. So know your audience and look to the other sources. That could be a postal worker, that could be convenience store clerks, anybody who comes into contact with folks who are experiencing homelessness who might know what where they're going to be staying. There also might not even be a service provider in the area. So consider partnering with any kind of regional entity, could be a retail pharmacy or a local store that would allow you to use like their parking lots or their premises for any kind of outreach that you want to do. And folks who work in rural areas know this, you can expect poor internet connection. And if you have internet hotspots that can work in those areas, fantastic. If not, make sure that the data you need to capture is available to be written down and then entered at a time when you can enter it. The next slide is the last strategy, which is mobile vaccinations. And these require a whole lot less infrastructure. You could do it with a team of 2 or 3 people. It could be highly mobile and you can move around to different locations. Those people could be your vaccinator and whoever else could be that support in the community, that street outreach worker, social worker, housing navigator, whatever complement of people is going to be best suited for your mobile vaccine event. These teams should be outfitted with everything they need to, and it can fit in one car, so it makes it pretty easy. Things like one easy tent to set up, a pack of emergency supplies, a portable refrigerator, and some personal protective equipment. The Oahu example earlier was a great example of how bare bones an operation like this can be and still be effective. Next, we got my last slide, which is vaccine incentives, which is not new information, but we're going to continue to talk about it. Incentives are an eligible cost under ESG CARES Act funds, and it's one of the tools you can use as part of your multi-pronged approach. Using incentives to access vaccine information is great, and yes, incentives are okay for boosters. The caveat being if ESG funds can only be used for vaccine incentives if there aren't already vaccine incentives available within that community. And that wraps things up for my content, but before I go, I wanted to have a general plug for the HUD Exchange. There is so much content developed there over the last year that if you are facing a challenge with any of this or generally anything with any of the HUD projects, I would be shocked if there wasn't a document that addresses it somewhere there. There is a ton of content there. A lot of the stuff that was developed there came from the communities in the chat box in this very meeting. So thank you for all of you for providing that content. My colleagues should be dropping some COVID-19 specific links along with the vaccine landing page, which also has a ton of vaccine information. That site gets updated all of the time, so check back there often. And my last shameless plug is the disaster response rehousing site, which is a great spot that organizes rehousing info by subject matter and provides a ton of community examples, so you can see how other folks have tackled these things in real time. So with that, I am done, and Norm, I'll turn it back over to you.
Thank you so much, Brian. And I'm just going to echo many of the things you said at the end there. At the beginning of the pandemic, we developed a ton of resources around safety planning, around rehousing, around data, around all kinds of topics. I'm realizing that many of you have been around since the beginning of the pandemic, but there are people who are new and may not have been aware of those things as we were developing them. So as Brian said, there are a lot of great resources out there. And the disaster response rehousing site, it just very nicely organizes just a plethora of resources around how to do rehousing well. And of course, given that we have so many resources to work with now, be it ESG, be it emergency housing vouchers, and more, it's just a great resource to take advantage of this really unique opportunity to house a lot of people experiencing homelessness. So thank you so much. Also wanted to do just a direct plug on especially on the data integration side. We know that data sharing is unique, and there are sort of unique circumstances in every community. We encourage you to reach out to us and request technical assistance, and we can have experts sort of talk through some of those issues with you and really sort of help you walk through it step by step, because we know it can be very, very challenging, and there's a lot of stuff where you just need a lot of expertise to be able to sort of sort through what you can and can't do, and we are more than happy to provide that for you. So thank you so much, Brian. If you have any questions for Brian, please feel free to type them in the chat window. We're going to move to our next presentation. I'm going to turn things over to Sharon Singer. She's going to walk us through how we're doing on ESG-CV funding. Sharon?
Hi, everyone. We haven't done an update on ESG-CV in a while after the September 30th deadline, but we know you've all been working hard, continuing to work hard. As you can see, we are a fraction of the way to getting all of the funds into IDIS. Just one ESG-CV2 grant remains, so we'll be able to celebrate when that is all done. And we are very close to having all the funds committed in IDIS as well, which really speaks to communities having a plan of action and knowing where their funds will be spent. And then we have just over a billion drawn, which gets us to 26.5% of awarded funds drawn. And as we know, your expenditures sometimes are even larger than what the draws show. And so as you see, our next deadline coming up is not until March 2022, but that is a big jump from where we are today. So I'm going to pass it on back to Norm to talk about kind of next steps and communication from our office going forward.
Thank you so much, Sharon. So one thing I wanted to mention is if you are a recipient of ESG-CV funds and you did not meet your 20% expenditure deadline for September of 2021, just a few months ago, either through draws or through your quarterly progress report, you will be receiving soon a letter from us that outline what the next steps are, what sort of information we'll need from you, and what is going to happen going forward. So just wanted to share with you that if you're sort of the point of contact for an ESG-CV recipient, you'll be receiving that fairly soon, and it'll walk through the next steps. We are obviously also, I saw a question in the chat window about the 80% March deadline. We are working on information to provide for people about sort of how we're handling that and what you'll need to do to meet that that expenditure deadline. So look for that in the coming weeks. So with that, I wanted to just see if we have any questions in the chat window. One thing I wanted to, one thing that sort of came out really sort of just this week as people were finishing their continuum of care applications, we published a notice for the point in time count and the housing inventory count. William, I wonder if you could just do a quick, like what's in there? Is there very much different, or is it similar to past point in time count and HIC notices?
Sure. So very excited about the PIT notice. As we stated in past office hours, there were not a lot of changes in terms of the elements themselves. So as your preparation goes forward it should look very similar to the past. A couple things to note though. So one, remember that tribes are now eligible as COC recipients and to participate as COCs. So there's a little bit of information in there about tribes. We will need to provide more on how to effectively count in tribal areas in the future as we learn more. We're also learning in this process as well. But the one big thing to note, if you're counting on tribal lands, which again, we encourage you to work with your tribes, you must get permission to participate or conduct the count on their lands. And that's really important. We want to honor that. So that's an important one. A lot of new guidance around kind of tough counting situations, for lack of a better term. I think we use the term ambiguous housing situations, but it covers things like counting in RVs, people in tents, tiny homes. These are things that people have asked over the past several years, and we've updated guidance relevant to that. So we will have an office hours next Tuesday from 2 to 3:30 Eastern time. Happy to answer questions then and look forward to the count. One last thing, there has been some confusion around whether or not the count is required. So one thing I do want to say around that. First, if you received an exception last year, you would be one of about 40% of the COCs. That exception was only good for that year. And there is a regulatory requirement to count every other year. So if you did not count, and that means you did not conduct any unsheltered count, you should be planning to do your count right now. We are expecting you to come in, and that's a regulatory requirement. If you did some kind of unsheltered count last year, whether partial or full, while it is not required to count this year, we strongly and very highly encourage you to do so. There are lots of reasons for that, as kind of came out in today's session, but we strongly encourage it. We need to better understand that population. There are ways to safely count, and we provided some safety guidance on that thanks to our partners at CDC and National Healthcare for the Homeless Council. But looking forward to good results this year and understanding better what's happened since COVID started for many of us.
Thank you so much, William. Just want to reinforce on the upcoming point in time count. Many of you probably saw in our continuum of care NOFA that we were there was a rating factor related to whether you were going to do a count in 2022. We are obviously very strongly encouraging people to do that 2022 unsheltered count. So thank you so much for that, William. William, there's also a question in the chat window that just came up about whether there's any LSA information forthcoming. Do you have any updates on that?
Yes, it will be coming hopefully early next week, but yes, we're planning on opening up the LSA process very soon. We had to nail down a few things on our end, and so before we send something and change dates or anything like that, we just want to make sure we have the dates firm, and we will provide that again. I would look for it next week. That's when we anticipate releasing something.
Great, thank you. Also want to mention, you referenced tribal organizations and tribes and TDHEs and such starting to participate in the Continuum of Care program. When we open the registration process this coming January, our plan is to have a process for tribes and TDHEs and for tribal areas to be included in the Continuum of Care process. So you'll see that when we publish it, hopefully not too long from now. But just wanted to mention that's on its way. If you are in a Continuum of Care that has tribal areas in it or nearby, we really strongly encourage you to have discussions with with tribes in your area and really start working together on how to really work together on ending homelessness on tribal lands. So thank you so much, William, for that. Also wanted to say a quick thank you as we're wrapping up here. Wanted to say a quick thank you. We know the Continuum of Care application deadline was this week on Tuesday. We know that everyone works incredibly hard to make that happen. This was obviously a more challenging year than usual for many reasons. I just want to express our thanks to everyone who worked so hard on that and got those applications in. We are just going to review as fast as we can and try to get those awards out as quickly as we can, but just wanted to express our appreciation and recognize the incredible work you all did to make that happen. With that, I don't think we have any more questions, so we're going to wrap up here. Again, want to thank everyone, want to thank our presenters. It was great to hear about all the outreach strategies going on in Chicago. So thank you so much, Thomas, for that presentation. And thank you, Barbara, for walking us through that, the administration's guidance on vaccine mandates for employers. And also definitely want to thank Brian for walking us through those great HUD Exchange resources. Also want to thank our team in the SNAPS office and our TA providers for supporting the call and just making this whole thing run smoothly. And lastly, want to wish everyone a great day. Hope you have a great weekend. And looking forward to our next call, next office hours, which I believe will be December 3rd. So with that, thank you all and enjoy the rest of your day, the rest of your week. And that concludes the webinar.